Welcome to Cambridge Health Alliance Health is Wealth. My name is Roberta Robinson. I'm Director of Marketing and Outreach for the Geriatric Division of the Cambridge Health Alliance, including the PACE program. Today we have with us Dr. Raj Paik, and Dr. Raj Paik is a rheumatologist with the Cambridge Health Alliance. Thanks so much for coming on.
Thank you, Roberta. Thanks for the introduction. Thanks for having me here, and hi to all the viewers.
So, Dr. Paik, among other things, deals a lot with rheumatoid arthritis, and I'm sure some of you out there have experienced rheumatoid arthritis. So, can you tell us what rheumatoid arthritis is?
Yeah, of course. So, rheumatoid arthritis is considered to be the prototypical most common rheumatic autoimmune disease, and we'll circle back to what that is. But it's a disease that affects the joints, causing inflammation. The smaller joints like the hands, wrists, ankles, toes are more affected compared to larger joints, but it can really affect any joint in the body. It is autoimmune. Autoimmune means that your immune system, which is your body's defense against invaders like bacteria, viruses, other foreign bodies, that very immune system gets dysregulated, starts working more than it should, and starts attacking parts and tissues in your own body. So that's where the term autoimmune comes.
I think that is kind of hard to understand for a lot of people, that your body basically attacks itself.
Right. To simplify it, yes, that's exactly what it is.
And
yes.
Although there's nothing we can do about that process, there might be other things to help maybe control it a little bit or relieve it a little bit.
Right, of course. So there's so again, when we say the immune system is overactive and is causing inflammation, we're sort of talking in relatively simple terms. It's really certain specific pathways in the immune system. So there's several different pathways that cause inflammation. Not the entire immune system is working more than it should, but those specific pathways do. And depending on what part of the immune system is overactive, you get different types of autoimmune disease. So we have fairly well established evidence that there are certain pathways like the IL-6 pathway, TNF pathway that mediates inflammation in rheumatoid arthritis. So therefore, the drugs that we use to treat rheumatoid arthritis focus on those pathways. So it's targeted therapy. So when we talk about treatment for rheumatoid arthritis, we're not talking about suppressing the entire immune system.
That's a good thing.
Yeah, you need your immune system. But it's more just focusing on those pathways that are causing the problem and sort of trying to normalize those levels.
Now, how does that happen? Do we know?
So, great question. We don't have a great understanding. There is more and more research, more and more data coming out. We know that there is some degree of genetic predisposition. So when they look at genome studies in rheumatoid arthritis patients, there are certain differences compared to patients who don't have rheumatoid arthritis. But interestingly, not everyone with those differences in the genetic makeup goes on to get rheumatoid arthritis. So that means there has to be something else along the line that triggers that sort of susceptible immune system, so to speak, to get actual rheumatoid arthritis.
Or maybe it lies dormant in the system and then those things irritate it and then causes a flare. Exactly.
So that's actually called...
That's where we come in, yes. Right? That's the piece that we have control over.
Right. So that's actually called the two-hit hypothesis. So the first hit is the susceptibility of your immune system. The second hit is, like you said, some trigger along the way. So we don't know whether it's some type of viral infection that your body gets exposed to, your immune system gets exposed to, and that triggers that susceptible immune system, whether it's certain foods, certain diets that trigger that immune system that's already prone to getting autoimmune disease. Or is it something else that we just don't know about?
Now, you said the word rheumatic. So that brings me back. My mother, as a child, had rheumatic fever. Does that, and she was left with a heart murmur. Is it connected at all?
It's the origin of the word rheumatic is actually from a term called rheuma, which means fluid. So it was fluid swelling in the joints, which led to that term. But rheumatic fever is very different from rheumatoid arthritis.
Yeah.
Rheumatic fever is an infection. You can have joint pain, joint involvement, and rheumatic fever, but it's not an autoimmune disease in the sense that, when we're talking about rheumatoid arthritis, it's not that type of immune system dysregulation.
I just didn't know, because when we talk about psoriasis and psoriatic, there is a connection. So when I heard that word, I just wanted to check it.
Yes. So that is important. The thing is, with the easy availability of antibiotics, rheumatic fever is much less common. So thinking back to maybe like 50, 60 years ago in literature, rheumatic fever was way more common. Now, not so much. So therefore, in common clinical practice, we don't really see it that much. But on the other hand, autoimmune diseases like rheumatoid arthritis are getting diagnosed more and more. I think partly just because the tools that we have to diagnose them, the availability of a rheumatologist or other specialists, the availability of blood work, x-rays, other types of imaging is just so much better that people are picked up earlier, which is beneficial, because the earlier you can treat and control symptoms, the better it is for long-term symptom relief and also to prevent joint damage from occurring.
So here's another question. I'm just thinking, if someone has history in the family and say they're in their 30s, would it behoove them to get a blood test to see or are they just predisposed? And should they just then do the best that they can do with their diet and exercise and everything to try not to get that?
Right. So in short, I'd say the latter. But it's a great question, because I have patients ask me that all the time. My mother had rheumatoid arthritis. Even if they don't have joint pain, they'll be like, can you run a blood test and tell me if I have it or if I'm going to get it later on in life? And the short answer to that also would be no. There's no one blood test that you can do and tell someone that you have rheumatoid arthritis or you don't, or for that matter, any autoimmune disease. Even if you talk about psoriatic arthritis or lupus or any of these autoimmune diseases, none of them have a blood test which can rule in or rule that out. The benefit of blood work is in the appropriate clinical setting. So if someone had, as I mentioned before, rheumatoid arthritis, one thinks of small joint involvement in a symmetric fashion, so symptoms fairly equal on both sides of the body, affecting the hands, toes, smaller joints. In that setting, yes, getting a blood test is important, because you want to get that extra evidence. If the blood test is positive, that lends more credence to your diagnosis, and you can sort of clinch that diagnosis and go forward with treatment. But in someone who doesn't have symptoms, it's not very beneficial. Just as an example, rheumatoid factor is one of the antibodies that we check in folks with rheumatoid arthritis. Anywhere between 5 to 10% of people have a positive rheumatoid factor, whether they have any autoimmune disease or not. So testing, sort of testing blindly is not really going to help you much. It might just be a source of lost sleep and worry because you'll be like, oh, I have a rheumatoid factor. When am I going to get rheumatoid arthritis? Right.
Right. Do we get rheumatoid arthritis? Not we, I'm taking myself out of that. But does it happen to folks at any age, or does the age factor play into this?
So it's more common in women. First of all, there's about a 4:1 ratio, female versus male. So much more common in women. Yes. The third, fourth, and fifth decade of life is so your 30s, 40s, 50s is when we, when rheumatoid arthritis is most likely to show up. But it can happen in kids. There's a whole branch of rheumatology called pediatric rheumatology. So children can get rheumatoid arthritis. It can start in your teens, 20s. And I have patients who were diagnosed with rheumatoid arthritis in their 80s. So there's no cutoff, but it's most common in your 30s, 40s, and 50s.
Well, that's interesting. It's all interesting because I know there are a lot of people that have rheumatoid arthritis out there because they tell me that.
Right.
There are a lot of diseases that fall under the umbrella of arthritis, like lupus does. If you look up, arthritis, you'll see lupus under there. I always thought lupus was a blood disease, but it's an autoimmune disease.
Right. So autoimmune disease and arthritis are both really broad umbrellas, like you said. There's many different types of autoimmune disease. There's many different types of arthritis. In rheumatology, these two things come together, autoimmune disease and arthritis, because a lot of rheumatic diseases like rheumatoid arthritis, like lupus that you mentioned, like psoriatic arthritis and so forth, do have some joint involvement to varying degrees. So there is some degree of arthritis in most of these autoimmune diseases, but depending on what exact disease you're talking about, that involvement can vary. So for example, a patient with lupus can have just lupus involvement of their kidneys and no other organ in their body. So that's just isolated lupus nephritis. On the other hand, another lupus patient may have a skin rash, joint pain, photosensitivity, so sensitivity to sunlight, and some sores in their nose or their mouth, and that's it. So that's still lupus, but that's very different from that person who just had involvement of their kidneys, but it's the same disease.
Right.
So it's highly variable, ranges on a spectrum from mild to severe involvement, and it can evolve over one's lifetime. So you can start off with mild symptoms like a rash or some occasional joint pain, and it can evolve into internal organ involvement, like affecting the lungs or kidneys.
Really? So, that doesn't sound like a good thing to have. We talked about psoriatic arthritis, and we've seen that commercial on TV. Up until a few years ago, I have a friend who ended up with psoriatic. Now you see the golfers on TV with psoriatic.
Phil Mickelson.
But it's a relatively new term to me, anyway, and I think to the general public.
Right. So you're exactly right. Rheumatoid arthritis was the focus. When we were talking about rheumatic arthritic disease, folks even thought that psoriatic arthritis was just a milder form of rheumatoid arthritis. It was several decades ago when it was recognized as a separate entity that patients with psoriasis of the skin, about a third of those patients develop this type of arthritis, which we now call psoriatic arthritis, which is similar to rheumatoid arthritis in the sense that there is inflammation in and around the joints, but also different in terms of what pathways of the immune system are involved in the inflammation and the pattern of involvement of joints. So I mentioned a couple of times small joint involvement in rheumatoid arthritis, symmetric joint involvement in rheumatoid arthritis, whereas in psoriatic arthritis, it's asymmetric most often. So it could be one knee on one side of the body, one swollen wrist, some inflammation in the back causing back pain and stiffness.
So it can affect any joint then.
It can affect...
It doesn't just stick with the smaller joints as a rule.
Right.
It
can, yeah. Yeah, again, it's all variable. That's what makes it fun in terms of diagnosis, because you have to not for the patient
from your perspective.
Just purely from an academic standpoint, it's fun. Just that exercise of going through these little clues and coming up with a diagnosis. But definitely not fun when you're having pain in your joints. But coming back to psoriatic arthritis, it is very different from rheumatoid arthritis in the sense that some treatments that we use for rheumatoid arthritis, we know that those don't really work well for psoriatic arthritis. So it's important to have a good handle on what the actual diagnosis is, because when you're then discussing treatment or planning to start treatment, then you want to pick the medication that's most likely to help with those symptoms.
That would be a good thing, because with every medication we have some side effects, and so we don't want to be taking a medication for nothing.
Right, absolutely.
Right. Or we want it to work.
Right. Or as an experiment, right? You mentioned those commercials. There's 30 seconds of the commercial followed by a minute of side effects.
Oh, mamma mia. it's like you'd be scared to death just paying attention to that, right?
Right. So part of it is that drug companies are mandated to list those side effects because the patient who's taking the medication should know what that drug can cause. So you want to be informed about how the medication is working, what it can cause, so that if you get a side effect, you know what to look for, right? And that's where your doctor, your rheumatologist comes in. You want to be able to communicate your questions, concerns freely. You want someone who listens to you and who's willing to discuss all of these things frankly with you. But the important thing is these side effects usually don't happen in healthy individuals. So most patients tolerate these medications really well.
Oh, that's good to know.
Yeah. And they are very effective in controlling the disease. So
the disease or the pain?
The disease itself.
The disease itself.
Right, exactly. Because we spoke about the immune system dysregulation, we spoke about those pathways. So we're using these medications to target those specific pathways that are driving the inflammation in the joints. So a medication to control symptoms would be something like ibuprofen or naproxen, which are just anti-inflammatories. Exactly. So they control the symptoms, but they're not really working on those pathways underlying all that inflammation.
Right. We need to get to the root.
Exactly. Right. So since we don't have a cure for these autoimmune diseases, the next best thing is to control the root of the problem, which is where medications that work on the immune system come in.
Yeah. That is really good to know, that it's not just a Band-Aid.
It's not.
That it goes
definitely.
right to the root of the cause. Now, I talked about fibromyalgia, which people, I've heard, that it's like if anyone's ever experienced tendonitis, then I've heard it's like having tendonitis all over your whole body, because it's your nerve endings, right?
Right.
But that's not, although that as well is under the umbrella of arthritis, that is not an autoimmune disease. Is that correct?
That is correct, yes. So it falls into that same umbrella just because the symptoms are quite similar to, for example, rheumatoid arthritis, especially from the perspective of a patient. When I'm looking in terms of making a diagnosis, I'm looking at very specific things like, is there swelling, even if it's really subtle. But from, if I were to think if I had these symptoms, I would just say that my joints hurt, I'm in pain. So that part is overlapping. The difference is that in fibromyalgia, it's your central nervous system that's hypersensitized to pain. So normally what happens is there's nerve endings in your periphery, like your hands, other hands, feet, other parts of your body, all have nerve endings. These nerve endings pick up pain signals, bring those signals to the central nervous system. The central nervous system processes those signals, and then you get that sensation of pain or no pain. The central nervous system in folks with fibromyalgia is hypersensitized. So what it does is it amplifies or multiplies those pain signals that it's receiving from the periphery. So you perceive pain much more than someone without fibromyalgia would.
So it seems, fibromyalgia seems so prevalent these days. Is it just because we're smarter and we know more, or is there a reason? And what is the reason, if there is a reason? Do we know that?
That's a great point and a tough question, Roberta. I don't know if I have a specific answer because, interestingly, in certain developing nations, fibromyalgia is much less prevalent than developed countries. Now, I don't know what the exact...
That's interesting.
Yeah, definitely, yeah. But we don't know what exactly it is, what the difference is. But fibromyalgia does tie in to a great extent with mood disorders. So folks who may have depression, anxiety, other mood disorders often tend to have some degree of chronic pain.
Which comes first, the chicken or the egg?
That's the tough question.
We don't know.
We don't know.
I mean, if I were in all that pain, I could see that could affect my mood, obviously.
Right.
But is it the mood disorder that
Right. So it's we don't know, and it's a vicious cycle. So if whatever came first, when when one is in pain, you're not going to feel good about it, and if your mood is low, you're going to be possibly in more pain. So it's a self-perpetuating vicious cycle. And there's another factor which is commonly seen as sleep disturbance. So whether it's sleep apnea or restless leg syndrome or difficulty falling asleep for various reasons, that also is often a big complaint in folks who have fibromyalgia type chronic pain. So knowing that it often becomes a vicious cycle, it's important when we talk about treatment to attack that vicious cycle at many different parts. So you don't want to just start someone, here's a medication, this is going to fix everything. No, because there's so many different factors that play into causing those symptoms. So if someone has depression or anxiety or any kind of mood disorder, you want to plug them in either with their PCP or with a behavioral health specialist, a psychologist, a psychiatrist, so that they can get the care that they need. Whether it's counseling, non-pharmaceutical care, or whether it's medication. And at the same time, you want to focus on physical measures like, things like yoga and Tai Chi have been studied in large studies and have been proven to be beneficial in chronic pain. So that's a resource. Working with a physical therapist. Now, I'm lucky that at Cambridge Health Alliance, we have excellent physical therapists, at my location in Malden, also in Assembly Square, in Everett Hospital, Whidden Hospital, there's physical therapy. So a good physical therapist can work with you, develop a comprehensive exercise program for you, with that sort of concept of start slow and sort of slowly build up your capacity, as opposed to, spending 3 hours in the gym in one day and then being in bed. Broken. Right. So
well, the thing is that when people are in that pain, and that's another vicious cycle, right? Because when they're in that amount of pain, they don't feel like exercising. The interesting thing is, if they do exercise, they would feel better.
Right.
But it's to get beyond
that hump. Yeah, exactly. So that's where things like yoga, Tai Chi, flexibility, balance exercises.
What about like water aerobics or something in the pool?
You read my mind. Oh. That was going to be my next point. So aquatherapy, water aerobics, water-based physical therapy is a great resource for fibromyalgia pain, or for that matter, any kind of chronic pain. Even my patients with rheumatoid arthritis or osteoarthritis often benefit from water therapy, because what it does is it offloads your joints. So you're not putting pressure on your joints, but you're still able to exercise your muscles, ligaments, get that flexibility going, build your strength. So often I'll refer folks for aquatherapy and physical therapy at the same time. So land-based physical therapy as well as water therapy.
And it feels good when we're in warm water.
Right.
True. It feels comforting.
Right.
After all, we came from water. Right. So I'd like, there's so much to talk about, and the time goes by so quickly, but does diet play a part in this whole thing?
Definitely. Diet does play a role. You are what you eat. In a way, all of these autoimmune diseases, as we're getting more and more data, we're learning that perhaps it is the gut, it is your gastrointestinal system that maybe that, we talked about that two-hit hypothesis, the genetic predisposition and something that triggers that. Maybe your gastrointestinal system is that second hit, that trigger, because they've done studies in patients with rheumatoid arthritis and lupus and in several other autoimmune diseases. And what they found is that the normal bacteria that reside in your gastrointestinal system, especially in the colon, are disturbed in folks who have autoimmune diseases. So normally there's about 10 to the power of 14. So that it's 1 followed by 14 zeros, whatever that number is, bacteria in your colon normally. And there's about 300 to 1,000 different species. In folks with autoimmune diseases, there's disturbances. There's some species that are more proliferating than others, and the overall diversity, those 300 to 1,000 different species, goes down. And certain barriers in your gut break down, which allow those bacteria to permeate your bloodstream, and therefore your immune system gets exposed to those bacteria. Normally, the gut lining forms a barrier between your immune system and those bacteria. If the gut is leaky, so to speak.
Right, we hear so much about that leaky gut.
Right. So those so the premise is that the bacteria gain access.
How do we keep it from leaking?
so we'll
the all important question.
Right. So that's where diet is important. So when we talk about diet, there's a couple of different things I want to touch upon. One is, we hear about these omega fatty acids, which, so there's two big ones. There's omega-3 fatty acids and omega-6 fatty acids. Omega-3 fatty acids are good because they reduce your levels of inflammation. So foods like So nuts, berries, fish, poultry, white meat in general is rich in omega-3 fatty acids, and you can even buy them in the form of a supplement. But in terms of foodstuffs, these are the foods that are typically rich in omega-3 fatty acids. Omega-6 fatty acids, on the other hand, increase your levels of inflammation. And omega-6 fatty acids are primarily derived from animal fat. So in theory, if one were to eat a completely plant-based diet, you would eliminate those omega-6 fatty acids, thereby reducing your levels of inflammation. So that is another thing that's becoming more and more talked about as plant-based diet and its effects on inflammation.
Right, and we hear that, and we don't always understand it. We think maybe it's for the vegetarians, but there's much more to it.
Right. There's much more nuance at this sort of chemical interaction level, these pro-inflammatory and anti-inflammatory chemicals in your immune system. Another diet that's talked about in the context of inflammation is the Mediterranean diet that's rich in olive oil, fish, fruits, vegetables, nuts, berries, and low in red meat, processed foods, that sort of thing. That diet has also shown some benefit in reducing levels of inflammation. So it's been studied fairly extensively, and it has shown benefit.
Yes, it seems to be recommended overall.
Right.
Well, our time is up, and so we'll have to bring you back to talk, because I'm sure there's much more to talk about. And we've just, I feel it's a tip of the iceberg that we scratched. So thank you so much.
You're most welcome. Thanks for having me.
Oh, my pleasure.